Norwalk Hospital is the first hospital in New England and only the 6th hospital in the United States to be nationally recognized for its leadership in the fight against lung cancer.
And we'll tell you what that means on this week's Health Talk. We're up next.
Hi, Vicki and I are back with Dr. James Bauman. He's a radiologist at Norwalk Hospital, actually played a major role in developing the screening program.
So tell us a little bit more. We started talking about the screening program in the earlier segment with Dr. Winter. Tell us a little bit more.
It was actually a major paradigm shift that people have been wondering about what to do with the #1 cancer killer in the United States for decades and decades. And there were a lot of studies and a lot of investigations, but the premier investigation, the one that was considered the gold standard, came out in 2011 after a 8-year study in which they took 2 groups of people who had a smoking history, took one arm and had them do low-dose CT scans and chest x-rays, and then followed them for a period of time to see what their outcomes would be. And it became so dramatic that they had to end the study early because the results were so clear-cut, they were putting the other arm of the research at risk. What they found, as Dr. Winter alluded to, was that there was a 20% reduction in lung cancer mortality with the patients who were having regular screening low-dose chest CTs.
Because they were being seen.
To be very clear, what that means is 1/5, 20% fewer patients were dying of lung cancer.
Exactly.
In those patients that had the low-dose CT scanning compared to a regular chest x-ray.
Exactly.
And we have a picture so we can compare those, because chest x-rays often don't show. Or here, maybe you could describe, and again, take our viewers through this. The right side is a chest x-ray, the left side is an image drawn off a low-dose CT scan. Take our viewers through what they're looking at here.
The chest x-ray is a very actually complex set of anatomy, a lot of overlapping structures creating a lot of black and white shadows that takes a great deal of time and diligence to try to separate out. It becomes looking at a needle in a haystack. The chest CT is actually a very simplistic way. You are dividing the chest up into individual slices or slabs, and then if something anatomically doesn't belong there, it becomes much more conspicuous, much easier to see, and by conclusion, much easier to deal with therapeutically.
So we're talking about, so a large lesion, when it's incurable, would be seen on a chest x-ray, but we're talking about very, very small cancers that are undetectable in chest x-ray, yet pretty detectable on CAT
These are CT. This is a CT scan and chest x-ray of the same patient. Is that right?
Exactly. Pretty much within the same time. I think within 4 weeks of each other, and the chest x-ray is interpreted, and appropriately so, as a normal chest x-ray. The chest CT shows a white shadow at the very top of the lung, which is what turns out to be an early stage lung cancer.
So we're really talking about that ratty looking round white ball at the top of the lung on the right, which is actually the left lung.
Right.
Now those tiny little dots elsewhere, those are blood vessels, aren't they?
That's what makes the chest x-ray such a confusing image to look at, is because there are so many overlapping structures. The lung receives a great deal of blood. They're both arteries and veins, as well as the air conducting passages, and they all create confluent shadows that an experienced eye has to learn to separate and dissect out intellectually into what is relevant and what is not relevant.
So Jim, the important thing about this picture then is that the chest x-ray on the right does not show the cancer, but a low-dose CT scan of the same patient at about the same time shows that small early cancer at the top of the lung.
Unequivocally shows the cancer.
So this
How large are we so what size is this tumor if you were to measure it?
To give you an example, the one that we just saw was about a centimeter, or about half an inch, roughly. Most cancers that are found on chest x-ray are on the order of 2, 3, 4 inches on average.
Okay.
So we have another video just to, again, show what a low-dose CT scan looks like. And this is actually like an egg slicer.
And here we go.
And what we're doing is we're going slice by slice through the individual's chest, and you can see that white shadow that pops up on the top as being a non-anatomic structure, which would then require further investigation for the high suspicion of lung cancer.
And so again, you're able to see the lung. We're going from back to front here, as if the body is sliced.
Exactly.
And we see it right there. There is the lung cancer appearing and then disappearing. As
exactly. The big white shadow is the heart in the middle. The black structures are lung and airways that conduct the air through our lungs.
But we really can appreciate on this video how small that really is, because you're only seeing it in a couple of slides,
exactly.
right? You saw it in maybe 2 or 3 cuts, and then it disappears.
Exactly.
So you can see if it's really embedded in the lung, you're not really going to pick that up necessarily on a chest X-ray.
Which makes why chest X-rays are such a difficult thing to interpret with the same level of sensitivity and specificity.
I think you could say just a couple of words. Obviously, the patient is not sliced up here, but it's actually the computer that generates these spliced images.
The patient's experience is extremely benign. They are basically lying on their back. The scan itself takes on the order of 10 seconds to perform. It's a moving table, a moving X-ray beam. The patient is lying. There are no injections. There's nothing
no
painful.
Pain, no preparation or
nothing at all.
else.
Nothing needs to be done except to lie still for 10 seconds, and the images are acquired by a computer, and much like our laptops and our iPads, creates a wealth of information that can be used in myriad ways.
Now, Jim, you call this a low-dose CT, and I think that we should make a point to say that we're really trying hard not to expose patients to high doses of radiation, but really be sensitive to how much radiation we're using, because we don't want to subject patients to other cancers down the road, which have maybe been linked to radiation exposure.
Radiation is a very big topic nationally and internationally, and just to put it in perspective, a low-dose chest CT is roughly the equivalent in radiation dose as a mammogram. It is roughly the equivalent of living in New Mexico or Colorado. It is less than the new breast tomosynthesis or 3D breast imaging they were doing by almost half.
Yeah.
And Jim, we're running out of time for this segment, but we've had some remarkable results locally at Norwalk that really confirm the national study. Maybe you could say a few words about what we've seen in, what, a year that this program has been?
In our first year, we had already discovered 6 occult lung cancers, meaning lung cancers in totally asymptomatic patients who had no idea that they were sick. Our ratio was 2.4%. Patients at risk were being diagnosed correctly as lung cancer 24 times out of every 1,000 patients scanned. Comparing that to mammography or colonoscopy, you only expect to find 5 per 1,000. We were finding 24 per 1,000.
And is that consistent with what they saw nationally as well?
Yes. Yes.
So this, in other words, this really works.
It works and it's cost effective.
Are you seeing a lot of women compared to men showing up for this screening, just to get a sense of the demographics?
I think it's been pretty much an even mix. Women are much more health aware. They tend to push their husbands to get these examinations done. Women have always been drivers of healthcare and self-help and being proactive in these efforts.
Yeah.
And Jim, maybe we've run out of time, but I do want to emphasize that this isn't for everybody. It's for people who are considered high risk.
At risk.
Right.
And what is that group of patients?
As Dr. Winters mentioned, the original research group were patients who had 30-pack year smoking histories, which he defined. Over the age of 50 to 74, there are arbitrary numbers, which was used in the study group to make the data statistically relevant. I wouldn't be scanning people who are 20 years old who have 1 or 2 cigarettes in their lifetime. That would be a waste of time, money, effort, radiation, etc.
So I think
well,
then they can access this through Norwalk Hospital. I don't know if there are other screening programs in the state, but this one is well established. So we'll be back after a short break. We'll be talking with a surgeon who actually has done a lot of innovative surgery in patients with lung cancer.
But first, let's take a look at some of our upcoming events sponsored by Norwalk Hospital. We're back with Dr. Sean Tittle, thoracic surgeon at Norwalk Hospital.
Sean, welcome back to Health Talk. It's always fun to have you.
I'm glad to be here.
So, Sean, we haven't talked much about the gold seal of approval that we just got from Joint Commission. You, as a thoracic surgeon, played a major role in this. Tell us a little bit about what that means, both to the people out there as well as to you personally.
It's a really big deal. It's a really big deal for me. It's a really big deal for our community. And one of the great things about Norwalk Hospital is I think familiarity, sometimes we just get used to what we have and we don't make a big deal out of it. But Norwalk Hospital has a long history of excellent cancer care and had a lot of pieces in place to take best care of patients. And I had a fantastic opportunity with Dr. Winter. He and I are the co-medical directors of the lung cancer program. So we decided to really put the lung cancer program under the most intense scrutiny in healthcare, and that is the Joint Commission that accredits hospital and healthcare institutions. And we were number 6 in the entire country to receive their highest degree of certification for lung cancer care.
That is really remarkable.
And maybe you can say a few words, because this isn't just simply applying for it and having somebody walk in the door. There's an awful lot that they require that you have in place, and without going through it in great detail, maybe you can just say a few of the things that you have to have in order to get this gold seal.
There are a lot of hospitals that have excellent doctors and excellent nurses and excellent care. The additional things that you need when you're going in front of the Joint Commission is you have to have proof and documentation of every step that the patients, that you had a discussion about advanced directives. For example, if they couldn't make their own decisions, what would they like done? Documentation that there's adequate social support and groups to help them deal with their diagnoses, documentation that you're tracking inside the program the times for delivery of care, and making sure that no one waits. And that's
looking at systems and looking at patient-specific functions as well. I mean, looking at making sure the patient has enough social support, for example, is looking at holistic approach to the patient.
The most important thing, and no one ever loses sight of this, I think, in our program, is the patient. And it really all comes back to how does that individual deal with that diagnosis and navigate through this entire process. We have people who help, just as simple as making appointments. And it's really building that entire machine that is about taking care of people and making sure that people get the care that they need as fast as possible. And then documenting how that works. That's what the Joint Commission looks at.
Really an integrated program of care for lung cancer patients specifically that involves a whole team, a large team of people. The other thing that I think a lot of people would be interested in is the Tumor Board, the fact that every case is discussed in a large group of experts, so everybody's getting multiple opinions for their case, even though they may not realize it. If you could say a few words about that.
I think that is exactly as important as you point out. You know, there are a lot of people who probably feel a little uneasy when they get a diagnosis that's that big. Lung cancer is scary. And so the automatic reaction is probably to run and get a second opinion, get a third opinion. Everyone gets every opinion of the physicians around when they come to Tumor Board, because all the pulmonologists will be there, the surgeons will be there. We have outside experts from Yale University who come down and help us with this, and Dr. Winter was integral in making sure that we collaborated as much as possible.
And that's important for patients to know. Do patients know this up front when they get their diagnosis and they're being navigated through the process of making appointments, et cetera? I think that's important information to give them, that we have a whole team of experts that will be reviewing your case.
Their pathology,
your particular,
their situation.
Exactly.
With the development of the lung cancer program, one of the great things that happened is we got better at understanding how to deliver this information to patients. And we got more comfortable with it, so now it's part of the routine where we will explain to patients, you know, you're going to have 6 pulmonologists, you're going to have 6 oncologists, or whatever the case may be, look at this and we're going to discuss your case.
Yeah. And so we only have 90 seconds left, but I do want you to say something about yourself, because I know that you do very advanced lung cancer surgery, minimally invasive, able to do some pretty remarkable things. Just say a little bit about how that's changed from the old days with the large incisions and the pain that I remember seeing patients experiencing.
It's it's amazing that people can recover. We want people to do well, to have the best possible operation. If we can do a better operation and get them back to their regular lives faster with the best chance of cure, that is the entire core of how to treat. So minimally invasive surgery is important. Having the highest seal of approval on a comprehensive team approach to a disease that kills so many people is something I think that Norwalk as a community can be extremely proud of, and that's the important thing.
And it's really a guarantee for the patients that they're getting the best there is.
Yes. There's only 6 in the U.S.
Well, again, we've run out of time, but I want to congratulate you and everybody else who's put this together. It makes me proud to be part of Norwalk Hospital, and I'm privileged to know you and the others that have put this together, because I think it's so important for patient care. It's so good for our community to do this. So if you have a question you'd like to ask Vicki and me on Health Talk, please contact us at healthtalk@norwalkhealth.org.
We would like to thank our guests today, Dr. Stephen Winter, Dr. James Bauman, and Dr. Sean Tittle, for coming on today's show. See you next week on Health Talk.
And if you smoke, consider getting lung cancer screening.
And consider quitting.
Absolutely.